Morning. I'd like to thank SAGES for the opportunity to present our work. Here are disclosures. So mesh infection remains a significant concern following hernia repair in contaminated fields. Specifically following the previous mesh infection, the risk of recurrence infection of a newly placed implant is significant. Given these concerns, there's a wide variety of surgical options used, primarily staged primary repair with delayed definitive reconstruction to single-stage procedures with immediate mesh reimplantation. Ultimately, the indications for repair are unclear and often based on expert opinion or surgeon preference. To address such questions, Murine models have been frequently used for the study of hernias and contaminated meshes. Unfortunately, most models simulate contamination by delivery of a standard concentration of bacteria to the operative field. However, this may or may not be an accurate representation of the clinical milieu. To our knowledge, no such model exists to simulate an infected mesh clinical scenario. Development of such a model would allow us to mimic this complex situation and improve our understanding of the pathogenesis of mesh infection, as well as test further implants and coatings. So for this study, we aim to develop a Murine model for this infected mesh scenario to allow replicable mesh and operative field infection. We wanted to determine whether removal of the mesh allows for clearance of infection, which is a surrogate for staged primary repair, and finally whether mesh reimplantation can be safely performed without reinfection, which is a model for single-stage repair. So to begin, we prepared a green fluorescent strain of MSSA that was used in prior studies. Bacteria were recovered from storage onto TSA plates with sheep's blood. A single colony was then inoculated into 5 mLs of BHI broth and incubated for 24 hours. From this, 1 to 50 dilution was placed in a 37-degree shaker for 2.5 hours, and this resulted in log phase growth with 10 to the 8th CFU. This was serially diluted to 10 to the 5th, and 100 microliters was used for inoculation. We did try lower levels in terms of CFUs per ml to establish infection. We found this to be slightly unreliable, and we also did mesh soaking, which generally resulted in gross mesh infection and need for euthanasia. So our study involved 36 female C57 black 6J mice, about 200 grams. They were acclimated for about a week. They then underwent polyester mesh implantation and then inoculation with 10 to the 4th CFU of GFP MSSA. These animals were survived for 2 weeks to allow for mesh infection to occur. We then explanted the mesh and irrigated the cavity with saline only. No antibiotics were used, and I'll kind of explain that later. At which point in time, they were split into 4 groups, with 6 receiving no mesh as a control, 10 polypropylene, 10 polyester, and then 10 porcine meshes. These animals were then survived for another 2 weeks, and then we did analysis. So gross mesh infectivity was evaluated at 2 and 4 weeks. This was either positive or negative value. Positive if, as stated, purulence on or around the mesh, around or biofilm formation, mesh expulsion, or a wound breakdown involving the mesh. We then did a quantitative analysis, which involved mesh and tissue explantation, which were weighed, and then these samples were homogenized, serially plated up to 10 to the -8th, and then we did CFU counts to determine a quantitative analysis, and this was only done at 4 weeks. So 35 mice survived. 1 mouth was actually euthanized after the initial mesh infection due to overwhelming infection. The remainder of mice had positive gross infection at 2 weeks with biofilm formation and purulence, and then variable infectivity at 4 weeks, and I'll kind of outline that. So here's the rate of reinfection at 4 weeks. So you can see our control group, only 1 out of the 6 mice demonstrated some area of inflammation that was consistent with what we would call positive for infection, and this was confirmed later with quantitative analysis. The remainder of the animals with mesh infection, only 1 polypropylene animal did not show mesh infection, but the remainder of the meshes, every animal had some form of repeat mesh infection after immediate mesh reimplantation. So here's some representative animals. So this mouse has no mesh. This is after the mesh removal. The field is clean. There was a little bit of kind of inflammation here. But this one spot of bacteria is actually to illustrate that we did inoculate this and this wasn't a fresh plate. But the GFP MSSA goes green, and I'll kind of show that. This is a polypropylene mouse. I picked one that had a lot of green to kind of show it. These were not the plates we counted. The polypropylene mice kind of they evidence some degree of integration, and then small bits of purulence around either the corners or where the suture was in the mesh. And I'll go over the quantitative analysis in a moment. The polyester mice had significant purulence, lots of MSSA recovery, and variable degrees of integration. The porcine mice, interestingly, they had significant biofilm formation, and these meshes were effectively not integrated whatsoever. They could be roughly plucked out of the field with little to no dissection. So here are our quantitative results. There was only one animal in the control group that showed recovery of MSSA, and that was 2.5 times 10 to the 5th CFU per gram of tissue. The polypropylene mice, again, 9 out of 10, with an average of about 4 times 10 to the 6th. And then the polyester and porcine animals all had mesh infection with about 10-fold more bacteria recovery than the polypropylene group. So in summary, I think we were successfully able to establish a polyester mesh infection and an infective operative field using the MSSA. It appears that infection will resolve with avoidance of repeat foreign body introduction, and that immediate mesh reimplantation results in reinfection of the newly placed implant, whether of synthetic or biologic construction. There's some important limitations. The Murine system is not representative of the clinical scenario. These animals have slightly different immune system, and thus we didn't choose to use antibiotics, and we just did saline lavage alone to kind of limit the number of variables that we were looking at. MSSA was used because it was because of the glow, we were able to distinguish it from other contaminants when we were doing our quantitative analysis. And unfortunately, we were unable to measure residual levels of contamination following mesh implantation to determine whether there was differences in how much contamination was left from the initial infection. And then there was limited data points in terms of how we could do the quantitative analysis. To address these, we are actually using IVUS imaging and then luminescent strains of MRSA and E. coli, which I think would be more representative of clinical pathogens. This allows us to do live monitoring, so the animals are basically anesthetized and undergo imaging, and we can test kind of the glow. This is a representative animal from a reference study. But this will allow us to actually do quantitative analysis without having to sacrifice the animals. And I think this will address some of the deficits of our initial model. I'd be happy to answer any questions you guys have.
All right, thank you.